everybody, welcome to AARC's Big Ideas Theater. I'm your host, Ed Hyland. Joining me now is Jessica Schweller. She'll be speaking at a session about adaptive servo ventilation and central sleep apnea. Wanted to get all that right. Jessica, thank you so much for coming by and joining us.
Thank you for having me.
Let's talk a little bit about the difference between central sleep and obstructive sleep apnea.
Well, what usually happens is that many patients don't know that they have a difference between the two. They'll come in presenting actually with similar symptoms of just snoring. They'll present with daytime sleepiness. They present with witnessed apneas at night. Someone's mentioning that they're not breathing correctly. They're not waking up refreshed. They're not waking up feeling like they're ready to go. And a lot of times they'll wake up with morning headaches. The biggest thing that we'll find is that when we do the sleep study at night, that's when we usually find the difference between the two. And what ends up happening is that we tend to find that when we're looking at their sleep breathing at night, there is this kind of mismatch in their breathing pattern. So what ends up happening is the brain is actually telling the respiratory muscles, stop breathing, hold that breath, rather than there being some sort of obstruction that's actually occluding the breathing or making the breathing more shallow. So that's where the difference comes in.
What type of patients are perhaps at risk for central sleep apnea, and how do you treat them differently?
So what we usually see is that obstructive sleep apnea can affect any type of population, but when we start to see centrals creep up, it tends to happen a little bit more in the older population. So generally patients 65 or older are at a little bit higher risk. Male population is a little bit higher at risk too, and that's been seen to shown because of the testosterone levels that can affect the apnea threshold. We also see patients who are on chronic pain medications, and now with the opioid epidemic being a lot higher, we're seeing more and more patients come into our clinic who have more central sleep apnea. Patients who have chronic congestive heart failure tend to be higher risk for having central sleep apnea, and those who have had a stroke as well. And so what happens is that a CPAP machine just isn't the run-of-the-mill treatment with these patients. We tend to have to put them on a more intelligent type of device that actually has a backup rate that kicks in and actually breathes for them during the night and adjusts their breathing patterns to what their normal breathing patterns could be doing.
So speaking as a slightly older person myself, give us some thoughts about how it can kind of, I'll say, sneak up on you. In other words, you may not even realize you have the symptoms, and yet you may have some type of sleep apnea.
That's correct. So a lot of times patients can come into our clinic asymptomatic. So what will happen is that we tend to see a lot of patients come into our clinic because they're being referred for other reasons. Their blood pressure is going up, they're having trouble controlling their blood sugars, or like I said, they recently had a stroke, or breathing changes are happening, or they were in the hospital and all of a sudden they see that they might be at risk because of some changes that might be happening when they were in the hospital. One of the things that we worry about is when these patients are asymptomatic, are they going to respond to treatment and want to be adherent to treatment?
Can you give us some thoughts on some of the challenges you find when working with servo ventilation for central sleep apnea?
The biggest issue we find is that there's cost. This machine is not very cheap, and so not only is there cost with the machine itself, but also the treatment options we have to go through and all the workup that we have to go through for these patients. So multiple sleep studies. A lot of times there's extra evaluations that we have to go through. So we have to do pulmonary function testing. We also sometimes have to do arterial blood gases. And as respiratory therapists, we know that those are not very painless. We also have to do a lot of things like echocardiograms for these patients to rule out what their heart function is. We also have to put them through, like I said, multiple sleep studies because the documentation has to be there just right for the insurance companies to pay for this. And if we don't have all the right, I's dotted, T's crossed, the insurance companies sometimes don't want to pay for this machine. And so the biggest issue we also have too with these patients is that we can't just follow up with them annually. These are patients that we have to see more on a 3-month, 6-month basis because their health status changes so much that this machine, even though it adjusts for what their health changes are doing, we might have to adjust a little bit more to what is going on with their health changes as well.
We were talking about that earlier, how just as you get a little bit older, it may
Exactly.
actually change the condition and how you need to treat it.
Exactly. With more and more of their pain medications changing, it might be something that they may have been on a more stable dose and then now they're on a higher dose, or with their heart failure status. One of the big things that we also have to worry about is making sure that their heart failure is managed. We also want to make sure that we're treating the underlying cause too. If there's something that's causing the central sleep apnea, that's what we want to address first. So treating that heart failure, making sure they're maximized. If they can get off the pain medications, ideally that's what we would like to see too.
Jessica Schweller, thank you so much for sharing some insights on sleep apnea.
Thank you so much.
And this is the Big Ideas Theater, brought to you by Draeger.